Hello, I'm Alain Combe. I'm the head of the ICU department at La Pitié-Salpêtrière Hospital in Paris, France. And I have the great pleasure today to discuss with you the first results of a prospective clinical trial we did on ECCO2R in mild to moderate ARDS patients and to allow with ECCO2R ultra protective mechanical ventilation. This is first my disclosure slide. So this trial use the Bactivantive Prismalum Plus device. The trial has been deposed on the clinicaltrial.gov website with an official trial number on which you can have a look if you want. And the trial was initially initiated by Baxter, which was the responsibility party for that trial. And I was the primary investigator of that trial. So a few words now about the background and the objectives of the study. The Prismalum Plus is a new ECCO2R device, which is using the Prismax RRT platform. This new device uses a membrane length of a surface area of 0.8 square meter, which is quite a big surface actually to provide gas exchange. And that device can provide ECCO2R either as a standalone therapy, where the membrane lung is used as a standalone device on the platform, or it can also be combined with an hemofilter, which is performing both continuous renal replacement therapy and extracorporeal CO2 removal. The objective of this PMCF Prismalum Plus study was to evaluate the safety and the performance of this new device in a population of patients with mild to moderate ARDS on mechanical ventilation using the Berlin definition. So for them, the PaO2 over FiO2 ratio was between 100 and 300 millimeters of mercury. The objective was to reduce the tidal volume to 4 ml per kilo predicted body weight, since there is a wide literature suggesting that this strategy may be able to minimize lung injury, lung-induced, mechanically ventilated lung-induced lung injury, and decrease the severity of ARDS, and ultimately to improve the outcome, and specifically the survival rate of these patients. The ECCO device, the Prismalum Plus device, was used to control the resulting hypercapnic acidosis, which is created by the decrease in the tidal volume from 6, which is actually for now the recommended volume for mechanically ventilated patients, to 4, which is a much lower tidal volume here, once again with the idea to decrease lung injury. This study was a prospective, multi-center interventional study in France in mild to moderate ARDS patients, and using this Prismax machine with the Prismalum Plus membrane lung to get ultra-protective mechanical ventilation. And to do that, we decrease stepwise the tidal volume from 6 to 4 ml per kilo predicted body weight. And the sweep gas, which is flowing through the artificial membrane lung, which is actually providing gas exchange was made of 100% oxygen at 10 liters per minute, and it was started once the PaCO2 was getting over 50 meters of mercury. And of course, there was a lot of measurements performed initially, and then at 8 and 24 hours after the start of ECCO2R. This is here the algorithm which was used to decrease the tidal step by step, first from 6 to 5, then from 5 to 4.5, and then ultimately from 4.5 to 4. At each step, there was a stabilization phase of roughly 30 minutes, after which blood gases were drawn, and the study was continued when the PaCO2 was less than 50. If it was over 50, the sweep gas on the membrane lung was switched on to provide CO2 removal, and the respiratory rate might have been increased to up to 30 to help control respiratory acidosis if needed. And we'll see that in the results of the trial. The PEEP was set according to PEEP FiO2 tables, using lower PEEP FiO2 table for mild ARDS and the higher PEEP FiO2 table for patients with moderate ARDS, those who had a PF between 200 and 300. So now let's get to the results. So the study took place from April 21 until December 23. We enrolled 58 patients with mild to moderate ARDS on mechanical ventilation. 42 of them received the therapy as a standalone, once again with the Prisma Lung Plus filter only on the Prismax, and 16 patients received the combination therapy combining renal replacement therapy with an hemofilter and CO2 removal with the membrane lung. The study population was composed mostly of males, in 74% of the population. The median age was around 64. The median PF was around 160. And the SOFA score at enrollment was 8.5, meaning that there was most of these patients had at least 2 or 3 organ failing at the time of enrollment. So once again, we reduced the tidal from 6 to 4, and during that phase, the peak hypercapnic acidosis was at a pH of 7.3, and the PaCO2 reached 53 at the time of the initiation of ECCO2R, and for most patients, that initiation of ECCO2R occurred when the tidal was between 4 and 5 ml per kilo predicted body weight. The venous access for the study was a double lumen catheter inserted through the jugular vein, and the blood flow on the circuit was on median at 350 ml per minute. We also measured the CO2 clearance of the device in 34 patients, and it was close to 80 ml per minute median at that time, which is quite high and much higher, for example, that the previous device on that same platform, which used a much smaller membrane lung. The median duration of ECCO therapy in these patients was 43 days, so close to 43 hours, excuse me, close to 2 days. So now let's have a look at the main results. So we reached our objective. The tidal volume was reduced, as you can see here, in the vast majority of the patients from 6 to 4, and this was highly significant. At the same time, we observed a significant decrease in the driving pressure, which is the plateau pressure minus the PEEP, which is believed to be one of the most critical parameter to induce ventilator-induced lung injury. The median value at baseline was around 12 and was significantly decreased around 10 in our patients when looking at the median value either at 8 hours or 24 hours. So once again here, a very important point about the performance and the delivery of the treatment in terms of driving pressure. We also measure the ventilatory ratio, which is an index of pulmonary shunt and alveoli dead space, which is highly correlated also to mortality and severity of lung injury. The higher the ventilatory ratio, the higher the mortality in ARDS patients. And with that strategy of decreasing the tidal volume, we observed a significant decrease of that ventilatory ratio to around 1.8 to around 1.2. Once again, this was highly significant here. So together with the decrease in the driving pressure, the decrease in that ventilatory ratio, altogether suggest a very significant impact on the ventilator-induced lung injury created by the ventilator in patients with mild to moderate ARDS. Another very important information here that the strategy had no impact on the blood oxygenation. The PF ratio was 163 at baseline and was not modified at 8 or 24 hours in our patients. This is very important here because there have been some concerns about the impact of decreasing the tidal volume on lung and alveolar recruitment here, which may lead to a drop in blood oxygenation, which was clearly not the case here in that study, which is also very good news about the strategy we used. We did not increase the respiratory rate to reach our objective of maintaining the PaCO2 below 50, despite the decrease in the tidal volume and the minute ventilation in these patients, which means that the membrane lung of the Prisma Plus device was highly efficient at removing CO2. This is very important here, specifically and when looking at previous studies, which also used CO2 removal devices in the setting of ARDS patients, especially the REST trial, in which there was a need to increase the respiratory rate to control respiratory acidosis when the tidal volume was decreased. In that trial, the tidal volume was decreased from 6 to 4.8. And despite that it was not 4 as we did here with our Prisma Plus, that REST study showed that there was a need to increase the respiratory rate to control respiratory acidosis. The pH remained stable, as you can see here. There was a slight increase in the PaCO2, which is expected because we tolerated a PaCO2 up to 50 milliliters of mercury in our patients. So now let's have a look at the safety parameters, which are another very important aspect of that technology, especially taking into account the observation of the REST study, which showed an increase in brain bleeding in the REST trial. As you can see here on that line, there were 5% of the patients who had hemorrhagic stroke, and 8% of the patients who developed major bleeding. Very importantly, our trial, the Prisma Lung Plus trial, did not show any major bleeding and did not show any hemorrhagic stroke, which is once again highly encouraging regarding the safety of the device used in that study. There was some adverse events, especially essentially minor bleeding. There was a very low rate of ischemic stroke. There was only one infection at the catheter insertion site, and there was some membrane clotting, but no pump malfunction or hemolysis, which was also a feature which was described in previous trials, especially the REST study, and also the Supernova pilot trial, in which the rate of hemolysis, especially with the Hemalung device, was up to 20%. So for safety, 3 minor bleeding, 2 occurred during ECCO2R, and 1 after the device was removed because the patient needed ECMO. Regarding hemolysis, there was no increase in aptoglobin, decrease in aptoglobin in our patients, and there was no signal also for an increase in serum-free hemoglobin in those centers who were able to monitor that parameter. We had 23 membrane clotting events in 16 patients, which is roughly 1/4 of the patients. And for 7, we had to discontinue ECCO2R. Interestingly, there was only 1 clotting when the Prisma Lung Plus was used in combination with renal replacement therapy, and we are working on that. There might be that the bicarbonate solution, which is used for reinfusion fluid during CRRT, might have some anti-aggregant or maybe anticoagulant properties, also leading to less clotting with that combination therapy. This is something which may be possible with no actual proof for now. Lastly, the mortality rate was on the low side at 31%, which is lower than the expected rate based on the SAPS-2 score, and also lower than the rate observed in other recent trials of ARDS with patients of comparable severity. And no patient died directly, mortality related directly to the ECCO2R therapy. So now, in conclusion, this study demonstrated the safety and the performance of the Prisma Lung Plus device connected to the PrismaX platform in adults with mild to moderate ARDS to reach what is called ultra lung protective ventilation, reaching a low tidal volume of 4 ml per kilo predicted body weight. And once again, with a significant, highly significant decrease in the driving pressure and the respiratory ratio, which are indices of severity and mechanically ventilated induced lung injury in these patients, and making sense for the use of this ultra lung protective ventilation in ARDS patients. And the device made it possible for us to avoid hypercapnic acidosis, which might result from the decrease in the tidal volume, which is obviously associated with hypoventilation and a decrease in minute ventilation. And once again, it's very important here that we did not have to increase the respiratory rate in that study, which is also another parameter which has been associated with worse outcome in patients with ARDS. So with that, I would like to thank you very much for listening, and I would be very happy to answer some of your questions. Thank you so much.